be on highlights of this workshop. And I'm going to ask our three rapporteurs, Jonathan Colasanti, Annika Alfonso, and Ellen Eaton, to come up to the front. And if you can take a seat. And then the sort of the rules of engagement are going to be, we're going to have about 10 minutes for each one of you, 8-10 minutes for each one of you, and then time for discussion. And hopefully you will not necessarily, we don't need a lot of repetition. It'd be more trying to highlight the workshop and hopefully to try to, I was talking to Rich Walensky, and we'll talk about it more later, but how do we create really, I mean, again, this whole issue, what are the actionable items? We're in the midst of a crisis, we're in the midst of an epidemic. What can we do, what can we recommend, what could we suggest that be done by the department, by other agencies now? Because, otherwise, the boat is going to sink and we're not going to be having done anything. So who wants to start? Ellen, you want to start? Okay, that's fine. Whatever order. I was just not going to give the guy the priority. That was all. Yeah, I was trying to be.
Just trying to be polite. Is it? Either way.
Why don't you go ahead?
Okay, sounds good. Is it okay sitting here, or do I need? Okay, perfect. So I just actually wanted to start from the very beginning and highlight a couple of the comments that the Assistant Secretary of Health, Admiral Garor, gave us when he opened the session. And I think the most important thing that he emphasized was that he and HHS are listening to what we're saying and that they're going to do their very best to translate ideas from this meeting into practice. He highlighted a lot of the statistics that we're all familiar with that I won't rehash here and reminded us of the 5 priorities that HHS currently has around opioid use, and that's better addiction prevention, treatment, and recovery services, better targeting of overdose reversing drugs, better data, better pain management, and better research. Rich Walensky, the Director of Office of HIV, AIDS, and Infectious Disease Policy, followed him and reminded us that we're really in a historical moment, one where we will mark the old way that things are done and see a paradigm shift to a new way that things will be. He emphasized that a new approach where we leverage any point in the broad health system, such as emergency department, clinics, hospitals, corrections facilities, and even the community as an opportunity to engage individuals in treatment and make that new process truly patient-centered. And finally, in the morning, Jessica Teitel, filling in for Nicole Green from the Office of Women's Health, reminded us of the impact of the epidemic, the opioid epidemic, and its infectious complications have on women. So not only are there epidemiological data that are slightly different between men and women, but fundamental biological differences between men and women that affect both the risk from opioids and the approach and response to both prevention and treatment for opioid use disorder. Patrick Sullivan from Emory University gave us a tour of maps and some epidemiological data and how that might inform our response. He really made the point of how infectious diseases can be used as sentinels for injection drug use, but we don't quite know yet what is the best indicator. He used the example that for all of those that he mentioned, HIV, HCV, and some of the bacterial complications, the only one that we have a national surveillance system for thus far is HIV. And so really the first big gap that I think was illustrated was we don't quite have the adequate surveillance systems yet to react nimbly to these situations. He also made the point that even if we did have comprehensive surveillance, the question remains about what would be the best indicator for injection drug use, whether that's infectious endocarditis, osteomyelitis, skin and soft tissue infections, drug-related overdoses, and he went on to list more. But the important thing, I think, is that we remember that any of these indicators we must be asking the question about what is their sensitivity and specificity for the issue at hand, what is the latency between injecting and that complication, and then, of course, what is the durability of the infection. And so while HIV is reportable and we have surveillance, the sensitivity and specificity for injection drug use is quite poor and the latency is quite long. So therefore, it's not a great indicator. HCV may be better. It may be more sensitive and more specific, but surveillance is certainly less robust and still has a long relative latency. The bacterial infections that I mentioned don't have any surveillance and probably aren't particularly sensitive and specific, but they have a much shorter latency, so they may be useful in that realm. He went on to provide examples from AIDSView and HepView of where estimates at national, state, and local levels really tell different stories. And the thing that I took away most from that was the importance of the granular data. So the national picture is great, but because our responses are going to have to be locally cultivated and driven, it's going to be very important to have good local data. Furthermore, during the question and answer period there was a word of caution about relying on surveillance systems because of the data lag, and it may not capture that entire story. And so particularly in talking to potential funders, we don't want them to get the picture of an epidemic that really was going on 3 or 4 years ago. After Patrick talked, Natasha Martin from UCSD gave an excellent talk on modeling and showing how the impact of modeling can have on shaping our policy and programmatic responses. So she briefly reviewed the effectiveness of certain harm reduction approaches, which we all know, whether that be opioid agonist therapies, syringe service programs, all reducing incidence of HIV and HCV. We know the evidence is clear. But what happens when we try to put those into practice? She gave really 3 poignant examples of different types of epidemics and how those shape her models and therefore hopefully our responses. So she gave the example of a slowly expanding epidemic in Perry County, Kentucky, where it's estimated that there would be a dramatic decrease in new infections by scaling up harm reduction alone, but that wouldn't quite get us to our goal of hepatitis C elimination, and you'd need to treat hepatitis C as well in the inject and drug using population. However, I think optimistically in her model, she was only treating 50 per 1,000 people who inject drugs, so it's a very realistic and achievable target. That contrasts with a rapidly expanding epidemic in places like Scott County, where a scale-up of harm reduction would not even reverse that increase in incidence of hepatitis C. And here you'd have to add in the treatment piece of hep C just to stabilize the prevalence. And so it was clear that in an expanded epidemic setting, you'd require much more intervention and often would need retreatment to really see a decline in new infections. So my takeaway there was we need to start the prevention before the epidemic even starts. And then finally, in a stable epidemic where the grass is always greener like San Francisco, a scale up of harm reduction really doesn't show much impact in the models because they're already probably doing it and catching a lot of that population. And in that situation, then scaling up treatment will give you a much kind of greater effect for that population. So I think importantly from her talk, it seems like the goal of hep C elimination is actually achievable, particularly the treatment aspect, realistic numbers of people that need to be reached to be treated, and I think that's a great message to give to our policymakers. And then we heard Miss Vita Moore's story, and I think it probably touched most of us in the room. And while it's important to understand the epidemiology and the impact of our therapies, we certainly can't lose sight of the human story that's behind all of this. At the end of the day, individuals like Ms. Moore are the reason why I think most of us are gathered here today. Addiction is a profoundly human experience at the center of the opioid epidemic and its infectious complications. We've heard about the lives, the homes, the families, and entire communities that are torn apart by addiction and by opioid use. And when listening to Ms. Moore tell her story, it took me back to the bedside of many of my own patients and reminded me sometimes to just shut up and listen. And that's when it becomes crystal clear that really the end result of an addiction is a product of circumstances rather than often decisions, and certainly not an individual's moral character. And so while I think all of us in this room understand that, we're going to still have to change that paradigm in the rest of the country and in the general public to move the needle with the opioid epidemic. She was asked a question about what her secret was, since she's done so well in overcoming her addiction and the success she's had since then. And she didn't really have a secret because it didn't seem like there is a secret. But what she did say, and I think that many of us in this room can appreciate, is she has a core group now that she can bounce decisions off of. And my guess is none of us make decisions in a vacuum, and probably decisions that are much less important than the decisions that she's having to make on a daily basis. And so being surrounded by a supportive community probably cannot be overstated. Her advice to healthcare workers was that we shouldn't be judgmental and just treat the darn thing. Her counterpart, Dr. Faledi Nuulia from Johns Hopkins, complemented her story with that physician viewpoint and the frustration of having to treat and retreat things like osteomyelitis, and as we're writing orders for potentially longer courses of antibiotics, knowing how ridiculous really that is because it's not going to achieve the end goal of reducing a subsequent infection. She emphasized the need for a comprehensive approach and that a patient should really not be able to touch a single point within our health system without being able to access treatment. She emphasized the need for multidisciplinary teams with social work, mental health, counselors, and other social support services because of the fact that addiction is often fueled by other unmet social needs. And without addressing those, it's going to be very difficult to overcome the addiction. And finally, she emphasized the role of her counterpart and the critical role of peers in this process to help others with addiction engender trust in a system that's often broken that trust, and it's hard for the physician to do that alone. Matthew LaRocca from the Louisville Public Health Department gave us a reminder of the impact of language that we use and the importance of using people-first language with regard to addiction. And I know that myself and I think many of us as clinicians have to continue to remind ourselves to do that in our daily practice. He outlined many of the barriers that patients face in accessing treatment. One really being an overall negative experience in the health system, so therefore it's a huge deterrent from coming back to that health system, and the waiting and the waiting and the waiting until the endocarditis or the abscess or the osteomyelitis occurs, and certainly not coming in preventive care because of the way they've been treated in the past. He spent some time focusing on women and how the hurdles for them can be even greater than for men because of the internalized shame and stigma, and particularly for women that have children and the fear of losing their children and breaking their families apart. There's a cultural expectation of mothers that make them feel that they have to do even better than the men in their life. And he mentioned intimate partner violence, and that women are often not in control of their supply, of their ritual, and all these things can lead to increased risks of infections. They, because of what they're tasked with, to take care of the home and to take care of the drug supply, don't have time themselves to go to things like syringe service programs. And he made the point that it can be even tougher for women to get relatively decent paying jobs that often require manual labor, and that may lead to increased risks of things like sex work to support the habit. And finally, he reminded us of the importance of partnerships between academic centers and treatment centers and community-based organizations to come down from the ivory towers and really interface with the communities and impact at the level of the individual. And then we finally heard in the early afternoon from Katie Burke in the San Francisco Department of Health, sharing the great work that they're doing to really end hepatitis C in San Francisco. And a couple key aspects of her model that really came up throughout the morning and then again in the afternoon and today were principles of community engagement, collective impact, equipping, and that may be with knowledge, it may be with naloxone, it may be with medical assisted therapy or HCV therapy, and having patient-centered models. She showed how they've integrated syringe service programs into primary care, as well as doing the reverse and bringing the primary care into syringe service programs. And how their San Francisco Drug User Health Initiative is doing what many in this room are really saying is needed, and that's making every door a portal of entry and a portal of support. And she gave the example also, I thought was quite poignant, about their drug overdose prevention and education program with the acronym DOPE. And what they've done is they've completely saturated the community with naloxone and educated the community on how to deal with overdose. And so they're getting incredibly fast first responses, oftentimes from users themselves, which she was making the point that they can be the most effective. And I'll end with saying, and I think it's important as we move forward to think about, she emphasized the importance of being nimble and being able to change our approaches, and they're having to face that now as fentanyl is just entering their community. So some of their education messages and how to deal with overdoses is having to change rapidly so that it continues to be effective in the community.